Okay, so today in this session, we'll be discussing on a colonoscopy cases, like what the guidelines we have, what they do, what is the basic necessity for this surgery, what could be the medical necessities for these. Okay, so colonoscopy. Okay, this for this you will get the series from 40,000 series. So basically, colonoscopy is the procedure that they will be performing to check any etiologies behind uh, any gastric related issues, especially for the lower GI related. Lower GI means large intestine, okay, starting from anus up to the cecum. So, physician will be examining all the way, starting from anal canal, sigmoid, descending, transverse, ascending, cecum until here. So total examination of this part will be done to understand better, like what could be the reason behind any sign and symptom, or there is also a possibility that they will be doing this procedure for any screening purpose. Okay, so screening, we have a separate set of guidelines anyways. For diagnostic procedure, we have a separate set of guidelines. We will see. So the entire study, starting from anus, physician will be advancing the scope from here. If you see in the next picture, like this, they will be advancing through the anus, rectum, and it will be slowly advanced through throughout this large intestine. So basically, at the end of this scope, there will be a camera. Through that, they will be able to see whatever is there inside the intestine. They will be able to see on this screen basically. So while doing this procedure, physician will be able to see the whatever is there inside this colon. They will be able to see on this screen, and they will be understanding like if there is any erythema, polyps, or diverticulosis, or any other thing, whatever it is there inside, they will be able to see here. So that's how they examine anus, rectum, sigmoid colon, descending colon, transverse colon, ascending, and cecum. So all these things will be examined. So the when the procedure starting from anus it and the scope is ending at the cecum, then it is considered to be a complete colonoscopy. Okay, to bill the service as a complete colonoscopy, the scope has to reach this part of the uh, intestine. Then only we will consider it as a complete study. If before reaching anywhere, if it is stopping, we have a set of guidelines that we need to follow. We'll see that. Before going into that, like these are the basic like common sign and symptoms. For that, they will be performing the colonoscopy. Okay, so blood in stool, constipation, bloating, rectal bleeding, change in bowel habits. It could be a diarrhea or constipation, anything, or specifically constipation, anemia, unexplained anemia, especially like they are not able to find out the cause behind this anemia, or abdominal pain, especially lower abdominal pain. Okay, so these are the common sign and symptoms where physician may warrant this colonoscopy to better understand like what is the reason behind this sign and symptom. Okay, so coming to complete colonoscopy and incomplete colonoscopy, there is a set of guidelines that we need to follow. So as I mentioned, basically the scope will be advanced from here. Slowly they will be advancing through all this area. So sometimes there is a possibility that due to some obstruction in any of this area, physician has to terminate the procedure in between. Okay, it may happen. So there are certain guidelines that we need to follow basically. So, one first criteria, we'll see one by one. First criteria. Okay, imagine physician has placed the scope here. They are able to advance here, here, here until here they have reached in this descending colon. Imagine there is a obstruction over here in this descending colon. So, because of this obstruction, physician is not able to pass the scope beyond this area. there is a big obstruction over here. If they still, if it is obstructed, they are not easily passing the scope. If forcefully, if they pull the scope, what happens, there could be some bleeding or something may happen, which may be life threatening to the patient. Okay, patient may have certain complications if they do it forcefully. So what they do, they will terminate the procedure here itself. Okay, they will not advance forcefully the scope, so they will terminate the procedure. So as I mentioned, to bill it as a complete colonoscopy, basically whenever they are advancing scope, it has to reach this area. But because there is a obstruction in the descending colon, they are pulling the back in between only, without, like, it is a incomplete procedure. uh Sorry, anybody has to say something? Okay. So because of this obstruction, they are pulling back the scope for the patient's well-being now. So this criteria. So in colonoscopy, we have a guideline that to build this procedure as a colonoscopy, the scope has to at least cross this splenic flexure. There are two flexures, one is splenic, one is hepatic flexure. These corners is called as a flexures. So this is the splenic flexure and this is the hepatic flexure. So to build the case as a colonoscopy, the scope has to at least reach or cross this area. Okay, then only we can consider the case as a colonoscopy. If before reaching this area, somewhere around in the descending or sigmoid or somewhere any of these area, if they are terminating the procedure, we have to down code it. Okay, down coding, it means actual planned procedure is colonoscopy, but because it has not reached the criteria to build the case as a colonoscopy, in between only they are stopping, we have to build down code it and build it as a sigmoidoscopy. For sigmoidoscopy, we have a specific CPT code range. So from sigmoidoscopy, you have to build your CPT, whether it is therapeutic or a diagnostic one. What is therapeutic, what is diagnostic, we will discuss later. But just keep in your mind that if the scope has not reached this area, splenic flexure, you have to down code the procedure as a sigmoidoscopy and you have to use a sigmoidoscopy code range. This is one guideline we have. Now, second criteria, physician has placed the scope advanced here, and then they have crossed this area and they have entered into this transverse colon, and they are also able to reach this ascending colon as well. But here there was a obstruction again, or maybe in the transverse colon there was obstruction, or here somewhere, anywhere it could be, before reaching the cecum basically. So imagine here or here there was obstruction again, so physician is unable to pass the scope beyond this area. Now here, as per the guideline, we can consider this case as a colonoscopy, but it is an incomplete one, because it is to bill it as a complete colonoscopy, it has to reach the cecum. But because of this obstruction, this has not reached this area. So what we can do is we can append modifier on this case. You can use the CPT for colonoscopy case only, but you have to use modifiers. Okay, so we have two modifiers, one is 53 and one is 52. So accordingly, you have to use 53 can be used on a diagnostic procedure and 52 you have to use on a therapeutic procedure. So what is diagnostic procedure? Diagnostic procedure means, imagine they are placing the scope, everything looked very fine, there was no problem, like no polyps, no lesions, nothing was there, no diverticulosis, or they have not taken any sample throughout the procedure. They just placed the scope, they examined, and they just pulled back the scope. That is called as a diagnostic. It means they are just investigating the colon without taking any sample. Sample means taking a biopsy or doing a polypectomy, doing some treatment basically. If they are treating something, it is called as therapeutic procedure. If they are just investigating, that's just doing the checking how well the colon is, how well the descending colon, how well the sigmoid colon, is there any polyp here, is there any diverticulosis here, just checking it. And they found that everything was normal, quite normal. They doesn't have to take any biopsy, no need of polypectomy or nothing they required. So they are just simply pulling back the scope. That kind of procedure is called as diagnostic procedure. In other hand, if they have found some polyp in the sigmoid area, sigmoid colon, and they have done polypectomy here, or they have found some polyp here and they are doing polypectomy, or they found some diverticulosis, so they are taking the biopsy of the diverticulosis. So anything it could be. If some treatment they are doing, some sampling they are taking, then it is called as a therapeutic procedure. So, after crossing the splenic flexure, before reaching this cecum, if anywhere in this area or in this area, if they are terminating the procedure, then you have to check whether it is a diagnostic procedure or a therapeutic procedure. Okay, so if they have not taken any sample, then go with diagnostic CPT, whatever we have for colonoscopy. And for that CPT, you have to use your 53 modifier. Okay, 53 modifier you have to use, discontinued procedure. And if they have taken some sampling like polypectomy they have done or biopsy they have done, it means it is a therapeutic procedure, but it is not a complete colonoscopy, somewhere they are terminating in between. Okay, in such case you have to use 52 modifier. Okay, whatever the procedure they are doing, like if they are doing polypectomy, use your polypectomy CPT and append 52 modifier. If it is biopsy, use colonoscopy biopsy CPT and give your 52 modifier. In that way you have to check. So basically they you have to check one by one, like colonoscopy. For that you have to consider the case as a colonoscopy. At least you have to check the like till where this scope has reached. If it is reaching this cecum, then only it is a complete colonoscopy. Before reaching this area, if somewhere it is terminated, then you have to consider it as incomplete colonoscopy. So, based on which location, whether it is in the ascending colon or in the transverse colon or in the descending colon or in the sigmoid colon, based on which anatomical site they are terminating the procedure, based on that you have to understand that whether this case can be billed as a colonoscopy or it has to be down coded as per the guideline, like it has to cross the splenic flexure. So if it is not reaching this area, you have to consider that as a sigmoidoscopy. Instead of billing it as colonoscopy, you are down coding it and billing it as sigmoidoscopy. Okay, and if it is crossing this area, then what type of procedure it is, whether it is therapeutic or diagnostic. Based on that, again you have to use appropriate modifier at either a 53 or a 52 modifier. Any of these modifiers will go along with your CPT code range. Okay, any doubts?
Okay, I'm having one doubt, ma'am.
Yes.
Actually, for that complete colonoscopy, we no need to use the two modifiers, right? Only
Yes,
for
no
that
need.
incomplete colonoscopy, only while taking back that scopy, for that only we need to use what is the modifier is like that. Which
Yes,
modifier?
exactly.
Okay, okay.
And that also modifier will come into picture if at least the scope has crossed the splenic flexure before coming in this region, like somewhere in the descending sigmoid or somewhere if they are terminating. Instead of billing it as colonoscopy, you have to bill it as sigmoidoscopy. And already you are down coding it, right? So no need of modifiers for sigmoidoscopy, you are already down coding it. Actually it has to be billed as colonoscopy, but as per guideline, as the minimal uh, area, how much it has to cross that area, it is not reaching that area. That's the reason we are down coding it. When you're already down coding it, no need of modifier. If it is crossing this area, as per guideline we can bill it as colonoscopy, but still it is an incomplete one because this tip of the scope has not reached the cecum. So that's why As this is considered to be an incomplete colonoscopy, you are appending either 52 or 53 accordingly as per your documentation, whether it is qualifying for a diagnostic or a therapeutic procedure. Yes, any other doubts, guys? Any doubts? It could be related to this topic or related to your training. Any doubts you can ask me.
So basically, if the CPT codes would be only appended if the colonoscopy reached to the specific location, like and it is reached to the sigmoid or it is reached to the hepatic flexure.
No, for down coding also you are appending CPT, but different CPT, not colonoscopy. There you are billing it as sigmoidoscopy CPT. CPT has to be reported.
Okay, location wise, we can report that CPT only,
Huh.
but not the complete colonoscopy.
Yeah. To bill complete, the tip has the like as it is shown in the picture, the tip of the scope has to reach this cecum. Then only we can consider it as complete colonoscopy.
Okay.
Before reaching this area, if any of these areas if they are terminating, then it is not a complete colonoscopy. So we have certain guidelines to follow. We have to append those guidelines as per the documentation.
Okay, fine.
Yeah.
Yeah, Anu, can you show them how to lead in the 3M or any, I mean, codify? Can you lead them once?
Yes, yes. Okay, you can go to first add procedure, then here colonoscopy 3. Then it will ask you whether it is a diagnostic, what they are performing, whether they have taken any biopsy or any control of bleeding, dilation they have done, or any tumor resection like polyp or any lesion resection, or ultrasound examination, removal of foreign body, like multiple things you will get. So if they have not taken any sample or they have just investigated, they have placed the scope, everything was quite normal, and they are just withdrawing the scope, then you have to go with diagnostic. Okay, then it will ask you whether it is done through natural orifice or through colostomy. So some patients who already underwent colectomy, okay, patients might have some intestine removals, right? Colectomies they have done, for them they will have the colostomy. So through the colostomy, if they are placing, like as you see in this picture, they are placing through the anus. This is the natural ostium. Anus is a natural ostium for every human being we have. But colostomy will not be there for every individual, right? Whoever has underwent colectomy, for those patients only will have the artificial stoma, which is a colostomy. So if they are advancing the scope through the colostomy, for that you will get a separate set of CPT. So it will ask you whether it is through natural orifice or through like artificial ostomy, then incision and all. So these two only you have to select anyways, natural or orifice. Then you will get diagnostic CPT 45378. If they are taking any biopsy, okay, biopsy you can select. Again it will ask you what type of biopsy, okay, whether it is removal of tumor or is it a normal general biopsy. Okay, then other. If it is normal biopsy, select other. Then specifically it will ask you whether it is in the rectum or intestine or both the areas. Okay, then no. Here it is asking PCS, this thing. So 453380, this is for the biopsy. Okay, like that, whatever you have you can lead as per the documentation. Okay, colonoscopy. And if they have done any polypectomy, you can go to polypectomy, natural orifice. It will ask you what type of uh, polypectomy it is. Cold biopsy, forceps, hot biopsy, forceps, snare technique, like the different technique. These are the different techniques we have for the polyp removal or biopsy. So you have to select which technique they have used as per the document. In documentation they will give you. If nothing was mentioned, only biopsy or cold biopsy they have mentioned, only biopsy or cold biopsy, it is same. Okay, whether it is just they have mentioned as biopsy, still you will consider it as cold biopsy only, or they are mentioning the polypectomy using cold biopsy forceps, then also it is same. Okay, so cold biopsy or cold biopsy polypectomy, CPT is same. There will be a change for hot biopsy and snare techniques. Okay, so whichever it is you have to select. Imagine it is snare. So if multiple polyps are there, multiple, they are removing through different techniques, then you can use multiple techniques also can be reported. Anyways, those all guidelines we can discuss in the like later sections. Now it's like just remember how to lead this one. Okay, here. Okay, I'm selecting it as polyp or ablation, removal of tumor, natural orifice. Then technique, I'm going with hot biopsy. No more procedures. If only one biopsy they are doing, you have to select it as no more procedures. If you have something else to report, like other technique also they have done, like one polyp in the rectosigmoid area they have removed through hot biopsy forceps, and one more polyp they are removing from other area with snare technique, then both can be reported. Okay, so now both you have selected, then no more procedures. No. 45384 for colonoscopy, flexible with removal of tumors or polyps or other lesions by hot biopsy. And 45385 colonoscopy, flexible with removal of tumors, polyps or other lesions by snare technique. So these two has to be reported if two they have performed. And also if three polyps are there, or they have done biopsy for other site and they are doing polypectomy for these two polyp removals, then all those things you can report. And if you see there is a edit, okay, code 2 of a code pair with 45384 45385, that would be allowed if an appropriate NCCI modifier were present. So it means they are stating that 45380 is a column 2 code for these two CPTs. If you append 59 modifier, okay, right click on the CPT and then go to add or delete modifier. Okay, then you will get the list of modifiers. Click on whichever the appropriate. 59 is the one which you will be using for unbundling. So as per this edit, it is bundled, like it is saying that it is a bundled service. So now you are appending 59 modifier to this. Okay, and if you see hot biopsy forceps, this is also, it is showing that it is bundled in 45385. So for this also you will have to add your modifier. Okay, so now you have given appropriate modifiers to this, but it is still showing that you can use XE, XP, XS or XU modifiers. This is specifically like project specific thing. Some projects may ask you to use this X modifiers for Medicare payers alone. X modifiers are specifically for the Medicare payers, not for the commercial payers. Commercial payers will always ask you 59 only. And this X modifiers also, they might ask you especially for certain set of payer facilities, not for everyone. If as per your client instruction they ask you to use X modifiers, then you can use. So what is this XE, XP, XS and XU is? This is more specific segregation of 59. So 59 or these are same basically. So 59 is more specified into XE. XE means separate encounter. XP means separate provider. XS means separate structure, or you can also use this XS for separate incision, or XU, unusual overlapping. Okay, so if none of these are applicable for your case, then you can go with XU modifier. Okay, so and like depending on your case study, you have to select any of these, or you can simply go with 59 as per the client instruction. You can do that. For each individual site specific SOP will be there. In that they will be mentioning what you have to follow. You just need to follow that SOP. That's it. Okay, clear? Any doubts, guys? Hello?
No, I think it's all right.
Okay, you can ask me not just about this topic, you can ask me any questions related regarding your training, like how will be the training, what will be covered, like any doubt you have, anything, any questions you have, you can ask me.
Hello.
Yes.
Yes, ma'am. I have one doubt.
Mm.
I'm if the session is continuing. You can repeat in the training session or not? Like, this
This
is it.
session, this
Yeah,
session,
this session. Yes, ma'am.
yes, again
This
we
is a
will be
demo,
covering.
or again you will repeat it.
Of course I will repeat it when we are
Okay.
discussing the four series section.
Okay.
It's just
Okay.
like very few, like it's not even a 5% of topic I have covered. It's just a demo session. It's a very little thing I have covered. Definitely again it will be covered during the training.
Okay. I have to ask one more thing. If I have to write down about the all the notes,
Mm-hmm.
so this is fast comparison to ever wrote it about. So I can wrote it in the recorded section. Huh?
Yes, of course you can wrote you will be getting those. And also like whatever the material I'm using, that will be shared, even that you can cross check after your sessions. uh, and also if you feel that, if any time if you feel that I'm going little faster, that if you have to note something down that I have mentioned, so you can stop me, please. Wait for a while, I have to note something. Definitely I'll wait at that time.
Okay. Thank you.
Meanwhile you can
Guys, this is purely a demo session. So don't think this is all the subject. Okay, she will be explaining you in a very decent manner. So this is all a demo session. This is a basic understanding for you.
Yeah,
Okay, sir.
because
Thank you.
if I take lot of too much depth now, it will be overwhelming for you guys. You cannot take it all uh, at very first session. So that's why I have just given you a brief introduction. That's it.
Okay.
Like each
Thank you.
CPT, whatever we get in this colonoscopy, I have not even given you the CPT code range as also, right? Just basic guidelines I have given, which that is also very nominal. We will be discussing all the set of CPT code range what we get in colonoscopy. Okay, no worries on that.
Okay.
Ma'am,
Yes.
soon after the training, can we get work from home opportunities, ma'am?
Guys, we can discuss all this after the session. Let her complete the demo first. Okay. Yeah, no,
Okay.
please go ahead.
Yeah. Yeah, so these are the this is the guidelines for whatever we have for a normal colonoscopy. Now we also have a different type of procedure, like different set of guidelines we have for screening colonoscopy. Okay, so basically screening colonoscopy is the one which will be performed for a asymptomatic patients. So why they have to do a colonoscopy on an asymptomatic patient? Because at a certain intervals, based on the patient's previous history or family history, they will consider that those patients are at risk for any colon cancers. Okay, so as I told you, these are the signs and symptoms that may for those physician may warrant this colonoscopy to understand like why this blood in stool is happening to patient, why this constipation is happening, why this rectal bleeding is happening, to find out the etiology behind all these signs and symptoms. To better understand the disease process, they will be doing the colonoscopy, whereas screening colonoscopy is done for the patients who are asymptomatic. They doesn't have any sign and symptom, but still they have to undergo the colonoscopy. So the basic reason behind this is for screening. Screening itself means it is done for a precautionary purpose. Okay, they will not wait until patient will start to have the sign and symptom of some cancer or anything. So in between only they will do this colonoscopy at a regular intervals, based on what type of risk the patient is at. Like if patient has like we have two set of category of patients, like who are at high risk and who are not meeting criteria for high risk. For patients who has a higher risk, they will get a shorter intervals, like they have to undergo the screening colonoscopy at every 3 years or every 5 years, like that. That will be decided by the provider anyways. So it means based upon the family and personal history, those things will be decided at what intervals they have to undergo. So basically the motto is, when we have to consider the case as a screening, is patient should be asymptomatic, patient should not have any sign and symptom during the procedure. Then we will consider it as screening colonoscopy. And for screening colonoscopy, we have a separate set of guidelines based on the payers. Payer means insurance. Okay, first thing, if in your documentation provider has mentioned it as screening colonoscopy, the first thing you have to do is check the insurance part. Okay, first thing you have to check the insurance part, whether it is a Medicare or a non-Medicare payer. If it is a Medicare payer, then you have to follow one set of guideline. Like first thing, for Medicare payers, we have G codes as well as 4 series code. Normally we have these 4 series code. Here we got 4 series CPTs, right? But for Medicare payers, along with this, we also have G codes. Okay, so the purpose of that G code is, these G codes can be used only on the patients whoever is undergoing the screening colonoscopy, which is a diagnostic one, where they have not done any sampling and they have not done any polypectomy, any ablation, nothing. No treatment was done. Only it was a diagnostic procedure. They have inserted the scope, they have examined everything, everything was fine, and they're just pulling the back scope. They have not taken any sample. Then you have to use this G code, G0105 and G0121. We have two codes, which is G0105 and 121. So 105 is for the patient's colonoscopy on individuals at high risk. If patient is not high risk, then you have to go with G0121. Now, question comes like how we understand whether the patient is at high risk or no. This will be understand by reading and understanding patient's history basically. Okay, we have to read and understand patient's history. Like what is, if patient has a personal history of adenomatous colon polyp in the previous history of patient's own, like personal history of adenomatous colon polyp, or patient has any personal history of colorectal cancer in the previous days. Okay, any history of adenomatous polyp or personal history of colon cancers, colorectal cancers. Okay, this is about the personal history. or family history of same, like family history of any adenomatous colon polyps or family history of colorectal cancers. If any of these are yes, any one, at least one is yes, then we will consider the patient at high risk. Okay, if all these four are no, 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 then you have to consider the patient as not meeting criteria for high risk. Okay, it means patient is at low risk. For them, we will consider they are at low risk for colon cancers. When they do not have any personal history or a family history, then we will consider patient is at low risk for the uh, colon cancer. So for them, the basic thing is for them the interval will be more, like maybe for 10 years, 12 years, or even 15 years, once they have to go undergo this screening. Okay, so this is about the Medicare payer if the procedure was diagnostic. Now, for Medicare payer, if the procedure was therapeutic, okay, during this colonoscopy, patient came in asymptomatic only, but during the procedure, they have found out some polyp in the uh, like ascending colon or somewhere, and they are doing the polypectomy. Imagine it is a hot biopsy polypectomy. Then what you have to do is, because this is screening colonoscopy and payer is Medicare, we have PT modifier. Okay, we have PT modifier. So PT modifier you have to append for Medicare payer when procedure is therapeutic. Diagnostic has converted into the therapeutic procedure, then you have to use PT modifier. Okay, and this PT modifier is applicable only for the Medicare payer. If it is commercial, you have to use 33 modifier. Anyways, commercial we will discuss later. First, we are talking about the Medicare payers only. So, for Medicare, if it is diagnostic, you have to use G codes G0105 or G0121 based on the patient is qualifying for high risk or low risk. Okay, this is one thing if it is diagnostic. If it is therapeutic, like diagnostic has converted into therapeutic, then you have to use PT modifier for Medicare payers. Until this, everyone clear? Any doubts?
So the J codes is used on the diagnostic, that is used only for the Medicare insurance along with the PT modifier.
CPTs will be same, but modifier is PT only for Medicare. CPTs you can use for commercial or Medicare for anyone, but not G codes. G codes are applicable only for Medicare payers. G codes are not applicable for the commercial payers. Okay, but 4 series CPTs can be used for either Medicare or non Medicare.
Okay, so G codes cannot be used along with the fourth CPT series.
Anyways, when you're already reporting this, why you will use again 4 CPT? It will
Yeah.
not come, because
Okay.
once it is a therapeutic, then why you will use this one? This will be applicable only if the case is diagnostic procedure, then you cannot build this along with that, obviously.
Okay.
See, technically this is applicable for the diagnostic purpose, right? Yes, any other questions?
This PT modifier we need to give only along with this G series, not with CPT codes 4 series, right?
No, for G series no need of any modifier. For this no need of modifier.
Okay.
See, wait 1 minute. It's better I give you here. See, imagine screening colonoscopy. Okay, screening colonoscopy they are doing. Now for this, 1 minute. Am I audible, guys?
Yes, yes,
Yes.
Anjali. Yes, yes.
Okay. So, screening can be on two types of patients. One is for Medicare, and here it is commercial. Okay, so first thing you have to check payer, which payer it is. So if first we are talking about the Medicare, so in Medicare, if the type of study is diagnostic study, okay, and other thing is therapeutic. Okay, so if diagnostic, you have to use G codes, HICPIC codes. G0121 or G0, what is that other CPT? 105. Okay, these two HICPIC codes we have based on whether patient is qualifying for high risk or low risk. You have to use G0121 or 105. Next, if it is therapeutic, you have to use normal 4 series CPTs here. Okay, normal 4. Anybody has something to say?
No, wrong press.
Okay. So if it is therapeutic, you have to use normal 4 series CPT with PT modifier. More importantly, with PT modifier. Okay, this is about the Medicare. For commercial, we do not have any that glitch whether it is diagnostic or a therapeutic. You have only one thing, like normal 4 series CPTs only you have to use. Okay, normal 4 series CPTs with 33 modifier. For commercial, you have to use 33 modifier. For Medicare, you have to use PT modifier if it is therapeutic procedure. For commercial, whether it is therapeutic or diagnostic, you have only one option, which is 4 series. This G series is applicable only for Medicare payers. Okay, now is it clear?
Yes, ma'am.
Everyone? Okay, so like what is the necessity of applying these modifiers? Any idea? Like any modifier, not just this 33 and PT I'm asking, like what is the basic purpose of a modifier? What is the meaning of appending a modifier?
Giving additional information.
Very good. Giving some additional information. So, for example, see, 4 series CPT if you are reporting, like colonoscopy with biopsy single multiple. So, without 33 or PT modifier, will payer understand that this is specifically the purpose of this procedure was screening? Will that payer understand without modifier?
No, they won't be able to understand.
Sorry?
They won't be able to understand.
Yes, they will not be able to understand that the purpose of this procedure was screening. So that's the reason we have to append this modifiers, like whether it either a PT or 33 appropriately as per the payer. So the importance of this modifiers is very crucial, because if you are missing this one, payer will understand that this is a normal colonoscopy. They will miss this information. This is all about, like, whatever the modifiers we are appending is, we are giving some additional information to the payer. Okay, what circumstances it is, why they have done, like all those things they will be understanding by seeing these modifiers. They will get some additional information, so we should not miss these modifiers. Okay, simply if you are reporting 4 series, it implies that it is a normal colonoscopy, but here your case is a screening colonoscopy. So if it is a screening colonoscopy, you should not give you should not miss these modifiers. So why these G series are not being appended those modifiers? Because if you read the CPT descriptor for G series, colonoscopy not high risk. Okay, here it is showing like this, but basically this will come as uh, okay, I'll show it here. Okay, this is the actual complete description of this CPT G0121. Colorectal cancer screening, colonoscopy on individual not meeting criteria for high risk. So, in the CPT descriptor itself, it is understandable that it is a screening colonoscopy, correct? So that is the reason for these no need of any modifiers. Whereas for like whatever the CPTs you are using here, 4 series CPT will not have that information. If you take 45380, I'll open it here. Colonoscopy flexible with biopsy single or multiple, that's it. There is no information that this is done for a normal colonoscopy or specifically for a screening. So that information is missing over here. That's why we are appending additional modifiers to give the information regarding the circumstances of the procedure. Okay, that is the logic behind the appending. Like what is the reason behind why we have to use these modifiers is that. Okay, clear? Yes, guys, any other doubts, clarifications, or anything you need?
When we have to apply
Ma'am,
Z0121 and Z0105?
Sorry, could you please come again?
When we have to apply the HEPIC scores like Z0121 and Z0105, what's the difference between them?
G0121 is for colonoscopy on individual not meeting criteria for high risk. Okay, if patient doesn't have any personal or family history of adenomatous polyp and no family or personal history of colorectal cancers, and patient's payer is Medicare, then you have to go with G0121. If patient has any personal history of either colorectal cancer or adenomatous colon polyps, or any family history of adenomatous colon polyp, or uh, family history of colorectal cancers, if any of these four are yes, then you have to go with G0105 for again Medicare payer. G codes are applicable only for the Medicare payers for screening colonoscopy.
Yeah, thank you.
Welcome. Yeah, somebody else was asking something.
ma'am, actually, that 59 modifier you told, right? Distant procedure modifier. What it means, ma'am? The distant procedure modifier, what it means? The distant procedure also means, can you explain that one more time, ma'am?
Yes. See, I'll open this one. Wait. So if you see, this is the CPT. This thing.
Yes, ma'am.
1 minute. 1 minute. Or I'll open it here. So if you see, these are all the colonoscopy code range we have. Okay, so taking from this diagnostic one, this is for removal of foreign body, this is for biopsy, this is for injection, control of bleeding, polyp, so many things are there. So there is a like one single encounter, they can do polypectomy, they may do biopsy, like biopsy they may do for diverticulosis, and they may do polypectomy for polyp, right? There is a possibility of these two, right? So when you are reporting these two, there will be a edit. It will tell that if 45380 and 45384. I'll show you here. See what it is showing. Code 45380 is a component of column 1 code. What is the column 1 code? 45384. So what it is showing as per this edit. So this is a yellow color edit, which is called as the column 2 code edit. Okay. Like there are two types of edits. Basically edits will be there whenever you are reporting multiple cpts, multiple standalone codes. Whenever you are reporting, there is it's not like every time you will get, but there is a possibility of getting a edit between any two standalone codes. You know standalone codes and add-on codes. Any idea what is a standalone code and what is an add-on code?
Standalone code will be the primary CPT, which can be appended only once. Add-on code can be applied multiple times with the units.
Okay. It's yeah, it's for some extent what you said is right. This is the primary cpt. Standalone code is the primary cpt, and add-on code is the one, like for example, if we take debridements. For debridements, they, like there could be multiple. It will be based on the amount of debridement they are doing. So if large surface area they are doing, we have to use the add-in codes for the additional units. So for additional units, we are appending like multiple units add-in code, whatever the thing you have mentioned. So basically add-in codes will never ever build separately. Those will always go along with the primary cpt. Okay. So add now we are reporting two individual cpts. So there is a edit between these two cpts. They are saying that biopsy is inclusive in this hot biopsy. Why they are mentioning? Because this is also biopsy, this is also biopsy. So they are stating, are these different or not? If these two, you think that these two are different, then please append a modifier. This can be reported with a modifier. So we know that, for example, why we are reporting these two. Example, like in my scenario, physician has taken uh, like biopsy sample of diverticulosis, and there was a polyp in the sigmoid or descending or ascending, whatever the area it is. There was a polyp also. So for that polyp they are doing hot biopsy polypectomy. Okay. So as a coder, I have read the report and I know that these two are two different procedures. One they have done for diverticulosis and one they have done for the polyp. So these two are different, right? Two different medical necessities are there. So two different. I know that these two are different, but this software doesn't know. So we have to give modifier to this to unbundle it. This is called as bundling edit. It is saying that 45380 is bundled in 45384. So as a coder, we have to unbundle it using 59 modifier. Okay, unbundling. Appending 59 modifier is called as unbundling. Okay, this edit is bundling edit. Clear?
Okay, ma'am.
Others also clear? Bundling, unbundling, 59.
Yes.
Great. Okay. So anything else you guys want to discuss or ask me?
No, it's all good. Thank you for the session.
Okay. Okay, then I'm done with my demo, Sunil and Uday. If you have something to say, you can go ahead.
Yeah, thank you, Anu. Thank you very much. It was a great session.
Thank you.
Uh, so, guys, if you have any doubts, we can start discussing. Manu, if you're comfortable, you can stay. Otherwise, I will be taking over the session.
Ask. Am I audible?
Yes,
Yeah,
yes.
I can stay for some more time, no problem.
Yeah, great. Thank you.
Actually, I wanted to ask that.
Yeah.
When we are going to start the batch?
ASAP, like probably within 2 days. Probably within 2 days.
Okay.
Yeah.
And how is the pay and its installment?
So, rather than discussing about the pay first, we will be discussing more about the opportunities, like the pay will be talking about the person who referred you. Rather than talking, you can reach out the person who was referred by you. So you can reach out him directly for the payment details. Rather than that, we can discuss more about how are the opportunities into the surgery coding, what are the importance of getting the job into surgery coding. We can discuss all this stuff if you want. Yeah.
Yeah. So that's also wanted to know.
Great. So yeah, please shoot out your doubts other than the payment details. We can discuss about the things like how will it will be helping you to crack the interview questions, or like interview assistance, job updates. These are more important, what I believe, rather than talking about the payment details. Yeah, payment. Yeah, we are really charging very nominal when compared to the institutes which are outside. We are not any institute. Okay, we are like the freelance trainers. Okay, so joining these sessions will help you out to get a job within a freestyle, and as soon as possible after you're completing your training, you have more opportunities. You have more possibilities to get a job if you attend these trainings. Okay, it's been
how long it will be? I mean,
it will be for 45 days. The training will be for 45 days.
45 days. Okay, fine.
Correct.
The timing for that, the evening timings only?
Exactly. The daily timings will be like 8 to 9 p.m. regularly. And Saturday and Sunday will be, mostly there will be no session. But again, if everyone is good and if the trainer is also available, we are good to go with the,
weekend
and yes. Not mostly we don't do it on weekends, but on
if it is necessary.
Exactly.
Yeah,
Exactly.
especially if we are missing some sessions during the weekdays, like there is a possibility of any emergency or something, right? If we are missing something during the weekdays for at least more than 1 day or something, so to cover up that, either we can extend for half an hour during the weekdays, or we can like catch up on the weekend to cover up those things. Okay, mostly for that. Normally, like it will be for Monday to Friday.
Okay, very fine.
So Prince, we have almost completed 10 batches till now. And in every batch, soon after completing their, trainings, and if you're regular in attending the trainings, okay, if you're not missing any session, and if you're regularly attend the session, see, we are here to provide you the recordings also, okay? Even if you're missing 1 or 2 sessions, we are happy to provide you recordings. But the thing is, my personal suggestion to you is, if you're not missing any sessions, and if you are able to join the sessions on time, and if you are concentrating on the sessions for 1 hour daily, and if you're not missing any session for 45 days, you can clarify your doubts, and I'm pretty sure that you will be learning like a surgery coder who is almost more than 3+ years experience coder. Okay, for example, your 5+ years experience into HCC, just for example. Okay, and soon after completing these trainings, you will be becoming like a surgery coder who is already having at least 2 to 3 years of experience into surgery coding. Okay, we will be molding you. Anu will be explaining you the things so beautifully. You will once you join the sessions, you will understand that. Or if you want us to refer you the previous batch people, we can provide you their numbers also. You can cross check with them. How are they now? How was they before attending the sessions, and how are they now after attending the sessions? So you can see the difference in yourself. Not, why I am giving you this reference is, we are not just here working for the money, okay? There are more opportunities into surgery coding now in the market, okay? So many people are showing interest in surgery, right? Like, why do you want to show learning? Why actually you wanted to learn surgery coding, Prince? Any such? Why actually? Can you explain? Anyone? Why do you want to learn?
Main for work from home reason.
Okay. Yes. Still, you have
Yes,
work
sir.
from home opportunities, but I personally suggest you, okay, please don't firstly prioritize work from home, okay? If you're just joining for work from home opportunities, yes, still there are many organizations giving you work from home opportunities, but please don't keep that as the priority. First priority should not be that. First priority is learning the subject. You should excel in the subject. Even though you go in office for 2 months, and if you're really doing good in coding surgery, then the office people itself are ready to give you work from home opportunities. But you don't join only because the surgery specialty is having work from home. This is my personal suggestion, okay? I'm not offending you people, okay? Because if you are just trying to concentrate on only work from home thing, please try to not join, because probably after 1 year you might be called in office. If you're not maintaining quality. First, uh, for example, you got an opportunity, you cleared your interview, okay, you got work from home opportunity, okay, you will be so happy. But if you are not attending the sessions, and if you are just want to clear the interview, guys, if someone wants to just clear the interview, Anu will make you clear the interview within just 3 days. Within 3 days she can help you clearing the interview. But if you're just clearing the interview, how does that help you? And if you're just going on the floor and sitting, and in the work from home, at least if you're going in office, you will have friends to help you, okay? Because you're all from different specialties, came here to learn surgery, okay? If you're going in office, you will be having an opportunity to learn excel more. But if you're sitting back in home, and if you're not learning any subject, it will be really tough for you. So I am pretty sure that you will be getting work from home opportunities. There are E&M and surgery. You have many work from home opportunities. There are people I see who are from E&M background, who are learning surgery. You will be really excelling into your profile, because if a person who is having E&M or ED with surgery or E&M with surgery, there are very less profiles in the market which has very high demand. So guys, again, my suggestion to you is, don't focus on work from home first. Focus on the subject, where Anu will be making you excel in the subject. She will be explaining you you feel that might be a silly doubt and I should not ask her, she might feel bad. No, if you are having any simple doubt also, she will be telling you 100 times till the time you get clear with your doubt. She will be not compromising. I'm pretty sure about that. So please first concentrate on the subject, and then 100% you will be getting work from home opportunities. There are many work from home opportunities in Chennai, Hyderabad, Mumbai, Delhi. If you are not any location constraint, if you're not with any location constraint, I'm pretty sure that soon after completing your jobs, you are 100% you will be getting a job if you are excelling in the subject. Without excelling in the subject, even if you are cracking the interview and if you are getting a work from home option, that will be really not helpful. So my request to you is always, please join the sessions every day. And the people who really have time, only join the sessions, guys. The people who do not have the time, and if I'm not able to join the sessions or something like that, please don't join the sessions. We will be doing every month. We will be doing the sessions every 45 days. If you are really busy, please don't join the sessions. If you are absolutely, even though if you are busy, if you can make time for 1 hour, if you want to change the specialty quickly, see, there are multiple people started learning surgery. Okay, now you are in a right time. If you delay the things, okay, if you start delaying the things, there are more people coming in, and you might lose the opportunity whichever what you have. So guys, start immediately where you have more opportunities now. So doubts please other than this. And we will be providing you all the recording sessions every day, but please do not depend on recordings. I personally suggest you just you be in the live sessions, and sir, I want to refer to the recordings, then we are happy to send you the recordings. But if you are not joining the live sessions and if you just want the recordings, it will not really helpful, because Anu will be in the live and you are in the live. You can clearly ask your doubts and get the clarification there and then itself. But if you are just trying to listen, depend on the recordings, and if you want to write it out, you might write it out or you might not write it out, and you feel like you want to ask the next day and you couldn't do that. I am pretty sure I have seen many people. See, we have in surgery we train more than 400 to 500 people. I'm not saying that every 500 person has got their jobs. I'm pretty sure that more than 150 to 200 people have got their jobs who have attended the trainings regularly and cleared their doubts. And we are here to help you on the interview pattern preparation and everything. It's just not the trainings. We will be giving you the job assistance. Okay. We are here to help you on, how to crack the interview. We are here to help you on how to change your resume. It's just not, it's just not that the training done, bye, just not like that. We are here to help you even after the trainings. It's just not the trainings. The first batch people are also still in touch with us, and even you after 10 batches also you will be touch with. Only the communication is important. If you start communicating with us, we are happy to help you. If you are just, if you just want to pay us money and if you want to relax, just depend on the recordings, I personally suggest you, we are not here to earn money. We are a group of team leaders and managers who's doing this session, so that we are happy to refer you into different organizations. Okay.
One more thing I wanted to add here, like for example, you have completed your 45 or 50 days of training in this batch and you're waiting for your job. So just for the meanwhile, if you are not attending, like if you are not being regularly listening to this surgery guidelines and all, there is a possibility that you may forget some few things. So if you are comfortable to join in the next batch as well, there is like if you are interested, then you can even join on the next consecutive. If you have doubts or if you want to be in touch and be regularly listening over the sessions, so still even after this batch, in the next batch, till you get your job, you can join the sessions, no problem. Okay, there is no restriction that you have already completed this batch, so you are not allowed to join in any other batch. It's not like that. You are allowed to join until you get your jobs. Okay.
Absolutely, guys. See, if you're going to some institute, okay, they will take you the full amount of money in the first day itself. And if you are missing their sessions, they will not repeat the sessions. And if you want to join the next batch, they will be again asking you the same amount, whatever you have paid in the first batch. But we are not like that. If you once paid us, you are eligible to join n number of batches till the time you get a job. We are happy to serve you. We are happy to discuss the doubts, whatever you have in the previous session. And if you might have missed with some XYZ problems, still, as Anu said, she is really helpful to, till the time you get your job, you are happy to join n number of sessions. That's what she said, and I'm adding that. And it will be no other institutes or no other trainers will be giving you such opportunity. I'm pretty sure about this. If you can, cross check with anyone, I'm able to give you the free sessions. I'm totally able to give you this batch also at free sessions. So guys,
Yeah. Excuse me.
Yes.
Yeah, sorry to disturb you.
No problem.
Okay, this is Pratyusha from Codex Academy. Actually, so I want to ask you something more.
Yes.
Is it just the theory part, or you will make the students train on the live softwares? Means you will make some live internship, like will you able to give the software access to the students so that they can practice live records, right? I mean, not live exactly, so that they can practice whatever they need to do there in the work, right?
Yeah. So we will be providing a dummy 3M link to you.
Yes, yes,
Like
that's what.
whatever I have used now, like 3M
Mm.
link, what I'm using now, that will be
Okay.
shared to you. You
Mm.
can you can, like, whenever you are going through or you
Practice.
are getting some time, you can
Mm.
open this and you can do your practice.
Yes, yes. Whatever documents you were provided for practice, we can use that software,
Yes,
right?
yes,
Yes, thank you.
yes.
Thank you.
Yes, guys, anything else? Make this platform like which will be helping you to go through all the surgery 10 to 60,000 series, and like make yourself well equipped, like as Shravan told. Like, see, getting into work from home, it's fine, but initially, as you do not have live work experience, at this stage, after completing your this thing, when you're going into some job, on a live job, it's always advisable to work with colleagues. Because see, in from home, whenever you're working from home, practically think that you're texting or calling somebody, there is a possibility of avoidance, because they will be busy with their targets. Okay, so there is a possibility of avoidance. They might not pick up your call. They might not they will ignore your messages whenever you're texting or sending some queries to them. There is a possibility, right? It's a human tendency. When we are busy, we miss to check, or we intentionally do it. It's a human tendency. But when you are lively present in your office premises, when you are directly calling and asking a question, they cannot avoid you straight away. So there is a possibility, like, you will get 100% of assistance from your peers who are already exposure in the surgery. So that will be a very good support for you guys. Okay, so like at least for a couple of months, if they are asking you to come to office, then we will give you work from home, then I would say it is a wonderful opportunity for you. So don't just stick on to work from home from the day one. If they are asking you, I would suggest go ahead and practice in the office. Practicing in the office will give you like more information, more support, everything. Like, you will be in live, you will be able to see, like, they will give you the shadow. When you are taking the shadow, like, you will be able to see all, like, from where all they are picking up ICDs, from where all they are picking up CPTs, what are all documentations they are referring, all those things you will be able to see. If you are sitting at home and just doing it through this live one at home, first thing, there will be a lot of distractions, right? Agree? Everyone agree? There will be a lot of distraction. If you even not agree also, it is a truth. At home there will be a lot of distractions. So when you are at a learning stage, give your 100%, then nobody is going to stop you. Because learning stage, if you are strong at this learning stage, it will like, you will be equipped with everything, like your documentation part, your guidelines, everything. If you are equipped with, then later on, after 6 months or something, you doesn't require anybody to support you. You can do it individually with very good results. Okay, so give little more like, extend for some extent. I would suggest at the learning time, even though it is little trouble for you, but go ahead with that. Because once you are taking a step to excel in your careers, do it little more, that's it. Okay, so at the time of learning, make sure you are learning 100%, so that you doesn't have to depend on anybody. uh, if you are with half knowledge, like, you will definitely face some troubles with your live work. It if you're equipped with everything, then no problem. But if you're with half knowledge or you're not giving that much time, then only you might face. Okay, it's not, we are not saying this to demotivate or something, but just to make sure that you are giving your 100%. That's it. Okay, it's not something like to demotivate or uh, like pulling your leg back.
So, guys,
One
again,
thing.
I'm saying you, we are not here for the business. Actually, we are very open so that you know, if we just say some fake news, we wouldn't have completed 10 batches till now. Okay, if we just wanted to, you know, not truth. If you're not saying the truth, the reality, you know some of the other day you would, after completing the batch, you would never refer any of your friends. See, many whoever joined now are referred by some xyz persons who have already completed their trainings before, right? So even though you get a work from home job, we are here to support. Okay, but again, you should be really really confident with these 45 days. These 45 days will be very very important for your next upcoming steps. If you just want to time pass, if you just want to get a job, see, forget about the job. First, forget about the job. I just want you to please concentrate on the subject. The job itself comes to you. If you are concentrating on the job and salary, you will end up learning nothing. So, yeah, guys, any other doubts, please feel free asking. This is an open platform. So, please feel free asking any doubts.
Yes.
Mm,
As you
yes.
said, you're expertise from different companies, right? In accordance with your experience, who are eligible, really eligible to learn the surgical coding, means experienced plus certified or non-certified also can learn. Who are really eligible for this? Who do you suggest?
Anyone
Whom do
can
you
learn.
suggest?
I would suggest every life science graduate can learn this surgery coding. But
Mm,
again, the person who knows at least the basic ICDs, basic
mm,
anatomy, the people
yes.
should be very good with anatomy here. Okay.
Mm,
So
okay.
that it will be any fresher who is good with anatomy can start learning surgery.
Is CPC is not
Because
mandatory here? Certification is not mandatory to start the career with
see, there are
surgery?
there are opportunities for non-certified coders also.
Okay.
There are opportunities for non-certified coders into surgery coding, but I'm not saying for freshers. Again, there should be at least 6 months to 1 year of experience in any of the specialty. I'm not talking it should be specifically into surgical. Okay, if
Okay.
you're 6 months experienced into HCC or 6 months experienced into ENM, would help you to learn surgery anytime. Yes.
Yes, yes. Certification is not mandatory. That's it. You're saying, right? Finally.
See, that's always an added advantage.
Add on
It's not
advantage.
mandatory.
Yes.
It's not
Yes.
mandatory, but
Mm,
always it's an added advantage. See,
mm,
if there are two people, okay, for example, the certified candidate not perform the interview well, but still he will be prioritized. The
yes.
non-certified person who really excelled in interview, but still he might not getting an opportunity sometimes because the client will ask you for a certified coders. Even though he doesn't have knowledge, that doesn't be a problem for the office people, because first they need to start their business. Okay, so they will
Yes.
pull that candidate, and half knowledge is also fine. They will start brushing their certified coder rather than non-certified coder. So the priority would be 100% the certified coders rather than non-certified. I would
Yes.
strongly suggest anyone to be certified
Before
when they come into coding. Yes, when they come into
Yes.
coding.
I
yes.
have one small doubt, sir.
Yes, Pranav.
Um, yes, in ED we have ED facility, Profi,
Yeah.
in ENM, IPOP. So in surgery also, are there any types, SDS, ambulatory, like that?
Yeah, even in surgery also we have like ambulatory surgery and SDS are more of the same, and we have general surgery. General surgery is also same, but when we compare to same day surgery or ambulatory surgery with general surgery, in general surgery more extensive procedures like which may require like 10 days 15 days of stay, like knee arthroplasty, knee replacements, or any major spinal surgeries or cranial procedures, like those are all are more extensive procedures, right? So those also will be getting in general surgery, whereas in same day surgery or ambulatory surgery, patient will be the patient stay might be maximum up to 2 to 3 days, not more than that, basically. So little minor things will be done in the same day surgery, not more extensive surgeries like colectomies, knee replacements and all will not be coming under SDS.
Okay, okay. So whatever
And
training we
have
are taking,
also uh,
is this for SDS related
yes,
only, right?
SDS, yes, right.
Okay, and more opportunity in the market there for SDS, for
Yes.
SDS.
Yeah, in see, basically in any interviews for surgery coder, they will ask you from SDS only. They will not go more deeper into these general surgery part and all, because like I would say only 10% of any surgery coders amongst all surgery coders, maybe 10 to 15% may have the exposure into this general surgery. Very rarely there are facilities who will be getting the more extensive procedures. Okay, so
Okay,
no need to worry. In general, they will ask you from SDS only. They will not
okay,
go
okay,
so deeper.
okay,
And
fine.
also, there is differentiation between facility coding and profi coding. As you said, like you like in ED, you will have facility and profi, right?
Yes,
Same
yes,
in as like surgery SDS also, you have profi coding and facility coding. Facility, you will be billing for facilities, hospitals. Profi means you will be billing for the providers, physician billing.
yes, right.
And we have separate set of guidelines, not so much of difference, but there will be a different modifiers and all. Documentation review part also little variation will be there for facility and profi. So that anyways we will be discussing later.
Okay, thank you, got it.
Yeah.
So does it include both here?
Yes,
Yes.
we
Okay.
will
Thank you.
give you what is the differentiation with regards to documentation part and all, but we suggest in your interviews, don't disclose that you don't mention that you know profi guidelines, because
Yes.
profi is little more difficult when compared to facility.
Facility. Yes.
Facility will be like little easier when we compare to profi, so don't mention that you know you have done on profi.
Okay. Okay. Thank you.
Yeah. Yes, any other questions, guys?
So guys, feel free asking. It's already 9:30. If you do not really have any questions, we'll wind up. Otherwise, we are still happy to answer your questions.
Sir,
Yes,
Yes, Krishna.
I'm a certified fresher. I will be able to work in this field, sir.
of course, yes.
Will I
See,
get a job with
until unless you are open to learn, if you are very consistent with your trainings and you are saying you are already certified, which certification you have?
CPC?
CPC. So you have already attended 1 to 6 series of questions, right, in your CPC exam. So
Yeah,
you
yeah.
have basic knowledge on it. So now in this training you will get more depth training regarding like more intense guidelines what we have for each specific this thing with regards to SDS. So you will be equipped with more deeper knowledge, so definitely you will be able to get it. Will be a very added point for you.
Yes, ma'am.
You are
But
more.
do
Yes, Krishna, please.
freshers have a openings for in surgery department?
Yes, Krishna. Yes. Like I'm not strongly saying you yes, but again, you are the more luckiest person, okay? Because in the meeting, there are more than 45 people who are maximum 95% people are experienced. And now they want to learn surgery coding, okay? Just think this, okay? Now you're just a fresher. And if you start learning now, you will be, by the time they learn 2 years of experience. Now, as a fresher, if you start learning surgery in 2 years, you will be excelling so nicely. And yes, again, I'm not strongly saying you that you will be having the opportunity as a fresher, but again, if you're going as a certified fresher, And if you're telling the interviewer that I'm already got trained into surgery department, they will be hiring you on a first priority with no questions asked. You got my point,
Yes,
Krishnam?
sir. Yes, sir.
You will be the first priority, and within no time, within 2 years of time, you would be probably reaching up to 50 to 60,000. I can strongly say that.
Yes, sir.
There are people, you are the most luckiest person, what I can say you is. But again, you should be very strong. You should be not depending on anyone. You should be sitting in the market, and you should be always searching for a job opportunity. And in resume, you should strongly mention that as that I am trained in SDS, so that you will be first prioritized. Though your salary is very less in the starting days, okay, within 2 years of time, I'm pretty sure that you will be reaching up to 50 to 60,000.
Yes, sir. Thank you.
Yeah, yeah. There
You
are
will be.
people with 8+ years of experience still not reaching 60,000 till now. But if you can learn things quickly, and if you spend your good dedicated amount of time on learning surgery, I'm pretty sure that you can reach 50,000 within no time.
Yes, sir. Thank you.
Guys, please, Pranav, Prince, Avinash, Prashant,
No, no,
Moni,
I'm fine with that. Yeah, thank you.
Swapnika. So, guys, if everyone is good with their questionnaire, we'll wind up, because you must have.
Hello,
Yes, yes,
sure.
Shivam. Yes, yes, Shivam.
Just share me with this audio.
Sure, sure. I'll do that. I'll do
Recording,
that.
because we joined late now.
No
So I will
problem.
share with
We'll do that.
I will share with my friends also.
No problem. No problem.
Yeah, sure.
Yeah. Thank you.
Sir, is this completely online, sir?
Yes, absolutely. Yes, this is a totally online session.
Live chats also will be explained online.
Yes.
Okay. Okay, sir.
Avinash,
No, no, no questions. I'm okay with it.
no question.
Thank you.
Sri Tulasi, Prashant,
No
Sriram,
questions. I'm good.
Swapnika. Please feel free. Don't hesitate to ask any question. We took all your dinner time, I believe, and we are very sorry, but you know this is really important for your next step of your life. If you want to really come into coding, this will really help you. So just for any questions, feel free calling us personally also. Thank you, guys. Thank you very much. Thank you, Anu. Thank you very much for your time.
Thank you. Thank you all.
Thank you all.
Thank you,
Thank you.
everyone.
Thank you.
Thank
Bye.
you.
Yeah, thank you. Good night.
Thank you.
Good
Good
night.
night, everyone.